No, thank you for the opportunity. Thanks for the time to letting me speak about superficial vein thrombosis, or also known as SVT. Hopefully, I'll give you a nice recap about this condition and why it's significant to us and our patients. So SVT, or superficial venous thrombosis, also known as superficial thrombophlebitis, used to be considered benign, self-limiting condition, and we'll go into details to how it is used to be. The incidence is fairly common, 1 in 1,000 in the US alone, but 125,000 cases reported per year, and that's probably an underreporting. An average range of age is between 54 to 65, right in the range where we see the majority of our patients with varicose veins, which is most often involved in this condition. And obviously, females, as we well know, suffer from venous insufficiency and varicosities more frequently earlier, at least in men. So what are the risk factors for this? Well, we already mentioned venous insufficiency, varicosities as a risk factor, but prior history, obviously, of a DVT or SVT, as those patients may have some form of thrombophilia, prior treatments, sclerotherapy, pregnancies, birth control, hormone replacements, obesity, immobilization, recent surgeries, the classic Virchow triads that we know, risk factors, right? The endothelial injury, stasis, and hypercoagulability, excuse me. The most common risk factors, however, is the presence of varicose vein, with 62 to 70% of SVT patients having varicosities. And of those patients, about 70% of them will have an associated superficial venous insufficiency. Within the diagnosis superficial venous thrombosis, we should keep in mind that some things might mimic it. Venous cystic dermatitis very commonly. With cellulitis, primarily the progression into a lymphangitis can sometimes be misconstrued as phlebitis. Erythema nodosum, bites, hematomas, Baker's cyst, those are all things that we frequently see in the office for patients concerned about possible SVTs. The clinical presentation is pretty classic. I think we're all very familiar with this: pain, erythema over the affected vein, palpable cord, sometimes low-grade fever and malaise. Of those in the clinical presentation, the most frequently we see it in the extremities, lower extremities. We can also see in the upper extremities, but obviously this can also present within the breast, chest, and the dorsum of the penis, and we'll talk about that in a second. And that chest and dorsum of the penis is referred to as Mondor's disease. For the fellows, please be aware, this is something that you might see in your test. It's a rare entity of thrombophlebitis affecting the thoracoepigastric, lateral thoracic, or superior epigastric vein, right? So whenever the inferior epigastric veins or their branches are damaged, that's when you see that classic sort of thrombophlebitis in the groin area or of the dorsum of the penis. The other presentation of thrombophlebitis that you should be aware of is Trousseau's syndrome, which is a migratory thrombophlebitis associated. The unfortunate part here is that it is associated with malignancy, specifically pancreatic cancer. So if you see this migratory thrombophlebitis, just be aware. This should make you think about malignancy, specifically pancreatic cancer. And finally, there's the suppurative superficial thrombophlebitis, which is unfortunately an infection of that phlebitis. These patients can be very sick. They can become easily bacteremic and septic. The management of this is surgical drainage. As you can see in this picture, obviously antibiotics are essential part of the treatment too. So why do we care about this superficial thrombosis, and how does it compare to deep venous thrombosis? Well, both DVTs and SVTs, if we already alluded, have similar risk factors. Okay? We have the age, the obesity, cancer, pregnancy, that a hormone replacement therapy, the surgeries, on and on. We touch on this. Unlike DVT, the main risk factor SVT is the varicose veins that we mentioned. But when we look at 3-month mortality, SVT has less than 1% versus DVT, which has about 5% mortality, and then obviously a PE 9 to 17% at 3 months. You say, okay, well, this is really a benign condition. Doesn't sound very serious. 3 months, less than 1% of my patients might have a significant risk. So, you know, some warm compresses, maybe some NSAIDs, and we're good. Well, let's start taking a look at some of the studies that challenged this classic way of thinking about this condition and how we address it. Okay, so first of all, we're going to take a look at Shenglis et al. They studied 236 patients with SVT and no concomitant DVT at the time of the diagnosis. They followed them up with an ultrasound 1 week later and demonstrated SVT progression to a DVT in 11% of those patients. 16% of those with proximal GSV thrombosis had an extension into the femoral vein, most commonly obviously via the SFJ. Proximity of the SVT within 1 centimeter of the SSJ compared to these patients the highest risk of progression to DVT. So now we start to see that, well, they may not have a bad mortality at 3 months, but they sure have significant risk of morbidity. And if we miss those DVTs, we are not addressing their patients' clinical health appropriately. Furthermore, we have the post study of 2010, okay, the post prospective observation superficial thrombophlebitis study. And this study looks at a French hospital community-based physicians, and they take symptomatic patients and they scan them for suspicion of SVT. And they wanted to assess the prevalence of thromboembolism in these patients with an SVT and to determine the 3-month incidence of thromboembolic complications. So at the end, they end up with 844 patients that had confirmed SVT of at least 5 centimeters in length. 25% of those patients they found had a concomitant DVT or a PE at the beginning of the study, right? So out of the 844, they went to get scanned. Oh dear, you already have a DVT or a PE. So of the residual 600 SVT patients without a DVT or PE and were eligible for this 3-month follow-up, 90% of these patients already had some form of anticoagulation. Now, what time of form of anticoagulation that varied, that's not what the study's strength is on or what they were focusing. But those 600 patients, they proceeded to a three-month follow-up, okay? Even with 90% of them anticoagulated, 10% of them had a thromboembolic complication. 3 of them had a PE, 15 had a DVT, 18 had extension of the SVT, and 10 had a recurrence. And again, you're looking at 560 something, I believe it was, had a already anticoagulation, and yet they still developed complications. So who was at a higher risk of complications at 3 months? What they found is male, prior history obviously of DVT or PE, previous cancer, and the absence of varicose veins. So this was concerning, right? Because we're thinking about SVT being most common in patients with varicosities. But in this case, those patients that had an SVT and had no varicosities actually seem to have had a much higher risk of complications at 3 months, progression to DVT, PE, or multiple recurrence. So you should start being conscientious that if you see a patient that has no external evidence of any varicosity, and you find that they have an SVT, they might be at higher risk of progression. You might want to start looking at that patient more carefully and follow them up closely. So overall SVT and DVT relationship to varicose vein, 20% of SVT patients with varicose veins go on to develop a DVT, and 60% of SVT patients without varicose veins seem to go on to develop a DVT. Let's look at another study. This is the STEPH community-based study from 2014. This study looks at 265,687 people, again, with suspected symptomatic SVT in a French community multi-center study over 1 year. They find out that the incidence of SVT is about 0.64 per thousand. And yet, again, they find that they had a concomitant DVT in about 24.6, 25% of patients, and a concomitant PE in approximately 4.7 of the patients. So again, really concerning that this is no benign condition. This evidence of superficial thrombophlebitis really carries some serious complications and risk for further venous thromboembolic disease. So how do we go then about diagnosing SVTs? Well, as we already start to see, history and clinical exam are critical, right? Those pain, hard, palpable cords under the skin, the erythema, the local edema, those are key. But we also have to pay attention to our anatomical location and thrombus size, okay? As we heard, many of these studies are looking at thrombus size greater than 5 centimeters in length. So that's where they started to see some of their the complications arise. And finally, we're all familiar with the need of duplex ultrasound. And I think this is a must when we start considering that so many of these patients have concomitant venous embolic complications into the deep system and pulmonary embolisms. We really owe our patients the need to have an ultrasound pretty much every single time, okay? Because you want to really assess the full extent of this disease process. So let's take a look at the anatomical part that we talked about, okay? So when I look at this, I say, think connected dots, right? Thrombosed varicose veins in the medial, anterior, posterior thigh. Well, you start to think about the great saphenous vein, to the saphenofemoral junction, common femoral vein, or mid-medial thigh phlebitis to GSV, or perforators extensions into the mid-femoral vein. Thrombosed varicose veins in the anterior lateral thigh, lateral leg. Well, start thinking an AAGSV to the SFJ or the common femoral vein via perforators, okay? In the posterior calf, obviously the small saphenous vein and through the SPJ into the popliteal vein. And laterally, you have the gastrocnemius, posterior tibials, and peroneals. Let's see how this looked in real life, okay? So you have this patient, SVT in the thigh. You can sort of see the skin hyperpigmentation. You can sort of see that cord. Obviously, we can't palpate it, but we can imagine that if we touch that, we feel that palpable cord that might be tender and inflamed. This is and just by location, we have to say, hey, is this AAGSV? GSV most likely. And obviously, I'm most concerned about extension into the common femoral vein and how proximal is this to the SFJ. And here is an extension image of the thrombus in the GSV extending into the femoral vein through the SFJ, okay? So this is how an anatomical location is going to guide your testing and what you should be really looking for. Here again is the AAGSV thrombose with extension of that thrombus into the SFJ region. In the lower calf, this is what we commonly might see. And we start to think about calf perforators, right? Is there GSV involvement? Is there SSV involvement? If there's SSV, how proximal to the SPJ? And the deep calf veins. And here's an image of that SVT of the GSV in the calf with a concomitant gastrocnemius vein thrombus involvement, okay? So we now identified our patient, we have diagnosed them. So how do we manage these patients appropriately? Well, we obviously have to manage their symptoms. That's why what brought them in the first place. We want to reduce the acuity of their symptoms, the pain. But we also want to prevent extension of this thrombus. We want to minimize the future risk of reoccurrence, as we've seen is a risk with his prior studies. We want to prevent, obviously, the progression into a DVT or a PE. So how do we treat this SVT? Short segments associated with varicosities, I would say, hey, the approach should be, these are perhaps low-risk patients, right? But you should follow them up for progression. You should do serial ultrasounds. You should evaluate them for chronic venous insufficiency and manage that condition appropriately. If the segment is large, greater than 5 centimeters, you should start considering the possibility of thrombophilia, called malignancy, especially if they don't have any varicosities. Okay, we discussed that. Okay, and have that patient properly referred. Extensive segments, watched for progression, perform occult malignancy workup again, perform thrombophilia testing, and risk of concurrent DVT and risk of PE. So we want to make it sure that we're looking at these patients in a multi-level approach and addressing their risk appropriately. How do we treat them? Well, this traditionally, as you know, we might have done warm compresses, some NSAIDs, perhaps an aspirin. Was this sufficient? Was this appropriate management for the patients? Well, let's take a look at the superficial thrombophlebitis trials here, treatment trials. First one, STENOX, which is a double-blinded randomized trial looking at 427 patients with leg SVT, and they were randomized to enoxaparin, okay, whether it was a 40 milligrams subcutaneous or 1.5 milligram per kilo subcutaneous, tinoxicam, which is just another NSAID, and then a placebo, and they looked at them for 12 days. The incidence of DVT at 12 days in the placebo was 3.6%. In the tinoxicam group, 2.1%, and the enoxaparin group, 0.9%, whether it was the 40 milligrams or the or essentially the 1.5 is essentially the same, 0.9 and 1%. Okay, so this study really what it does is says, hey, for the first time, low molecular weight heparin is better than NSAIDs for DVT prevention in these patients with SVT. All right, it does not really do a great job in terms of providing guidance on duration of treatment, but it introduces low molecular weight heparin and saying maybe these patients should all really be anticoagulated. So again, management, NSAID aspirin, that's we're getting that. We're compression obviously for our patients. Should we start using prophylactic dose versus intermediate dose low molecular weight heparin? They're both confer about the same risk reduction. And what about now NOACs and DOACs, right? Low molecular weight heparin has a compliance issue with having your patient to inject themselves. Do we have any data on that? Well, let's take a look at the Callisto trial. Okay, I think you are all probably familiar with the Callisto trial. And the Callisto trial is a randomized double-blind placebo-controlled trial of 3,002 patients with an SVT greater than 5 centimeters in length. Okay, these patients were treated for 45 days, either with fondaparinux, which is Arixtra, 2.5 milligrams daily. A fondaparinux, if you're not familiar with it, is a subcutaneous factor X inhibitor, so it is an injectable, versus placebo. Okay, the primary efficacy outcomes that we're looking at were death, symptomatic PE, symptomatic DVT, symptomatic extension, or symptomatic reoccurrence, okay, of their SVT. Pardon me. Their exclusion criteria was the DVT or PE at time of diagnosis of enrollment, cancer treatment less than 6 months, thrombus less than 3 centimeters from the SFJ, and SVT post-sclerotherapy, IV line related SVTs. They have liver failure, renal failure, platelet counts that are too low, obviously, like prior ligation of the SFJ, extensive surgery in the prior 3 months, prior thrombophlebitis in the prior 3 months, or DVT or PE in the prior 3 months. So pretty extensive exclusion criteria. And this is sort of the baseline characteristics of the study. There's slight predominance of females, but other than that, a pretty representative of our typical patients. So what did they find? They find that from the Varicose group at 2.5 milligrams per day for 45 days had a 5% absolute reduction in the development of these complications. And they had an 85% reduction of symptomatic thromboembolic complications or death. These are both statistically and clinically significant reductions in the primary efficacy outcomes, okay? So very significant here that now we have a factor 10 inhibitor providing a great data supporting its use in our patients for at least for 45 days. So the placebo group, how did they do? Well, thrombotic complications occur more often, okay? SVTs involve the greatest saphenous vein in 92% of patients, extended within 10 centimeters of the saphenous vein in 9% of the patients. They involve the veins above the knee more frequently, and the if VTE or SVT had occurred previously, these patients were at a higher risk. But the other key thing here is the number to treat, okay? In any therapeutics that we use, that number to treat, we want to make sure that it's appropriate, because if we're only trying to prevent one complication in a million, it might not be worth the cost, the time, and effort, right? But in this case, that number to treat, okay, if the primary outcomes was 1 in 88, right? So every 88 patients you treat, you're preventing 1. Now, you compare this to some of the other therapeutics we do in medicine very commonly, such as statins. Statins number to treat for prevention of a myocardial infarction, I believe it's around 250, and for stroke, it's like 300. So much higher number. So this is a much more significant number. We don't need, we're doing a lot of benefit by treating these patients with SVT and preventing these primary outcomes, which are significant. So we already touched upon some of this, the strength of the trial, okay? Patients were representative of what we see in the general practice, okay? First randomized trial to address the optimal dose and duration using a DOAC. However, this is an injectable DOAC, right? So you, just like low molecular weight heparin, enoxaparin, Lovenox, you're gonna have compliance issues. There are gonna be patients that are not willing to inject themselves, okay? Also, the cost of Fernandez is not really, we don't see it here in the United States, but outside it's still fairly costly. So it might not be, whether it's worth this or not, it's unclear. So maybe if we could use some of the cheaper DOACs, some of that provide more compliance, we could obtain better results for our patients. Okay. Also, this study is not an active comparison with low molecular weight heparin or aspirin, so we do not know if DOACs do better or worse compared to those. However, this study is strong enough that based on the Callisto study, the CHEST guidelines now recommend 2.5 milligrams of Fernandez for 45 days for the treatment of SVTs. Okay, this is a grade 2B recommendation. But then we have the SURPRISE trial in 2017. And the SURPRISE trial takes a look between 2012 and 2016 at 485 patients that were enrolled in the study, and 472 that were randomly assigned to 10 milligrams of rivaroxaban group or 2.5 milligrams of Fernandez. Okay, so now that we're comparing those two DOACs versus each other, obviously one being subcutaneous administration and the other one being oral. In the 435 patients included in the pre-protocol analysis, the primary efficacy outcome occurred in 7 patients out of 211 patients in the rivaroxaban group, and 4 out of 227 patients in the Fernandez group. So there were no major bleeds in either group. They had, I think, one in each of the groups. And so again, these studies demonstrated that ribaxamine was not inferior to fondaparinux for the treatment of superficial vein thrombosis. Okay, and it could offer patients with symptomatic superficial vein thrombosis less burdensome, less expensive treatment option instead of more expensive injection. Okay, so this is great. Now we can actually start providing another tool in our armamentarium to treat these patients with SVT and prevent them from progressing into their complications. So finally, the CHEST guidelines, okay, I already alluded to the 8.11, which recommends fondaparinux or low molecular weight heparin for 45 days over no anticoagulation. I think with the surprise draw, we can safely say that you can treat these patients with ribaxamine for 45 days also. In patients with an SVT who are treated with anticoagulation, they suggest fondaparinux over the prophylactic dose. So again, I think with the surprise trial and the lack of inferiority of the two DOACs, pretty much them being equal, I would obviously opt for the oral anticoagulation. It's easier, more readily accessible, and cheaper for our patients, at least with the pharmaceutical support that we have in the United States. So in summary, I think we pretty much have shown that SVTs are not a benign condition, okay? It's really a spectrum of venous thrombotic disease. 25% of SVTs have a concomitant DVT and 5% have a PE, okay? So make sure to get an ultrasound in these patients. Make sure to ask carefully about the review system, especially the cardiopulmonary, okay? Don't forget to evaluate the other leg. Okay? Obtain an ultrasound, as I mentioned, in all of these patients. Reassess your patients. Serial ultrasounds, we have that that luxury readily available. They are to our patients. And don't forget the rule of fives. If it's more than 5 centimeters in length in varicose vein or GSV, treat, or if you are within 5 centimeters of the SFJ or SPJ, please treat. And I'll open it for discussion.
Thank you, Eddie. That was a very good and comprehensive review. So I have several questions. So going back to the Callisto trial for a second. Mm-hmm. So those 6 inclusion criteria, or I'm sorry, endpoints rather, you have to keep in mind that was a combined endpoint. They took all 6 of them together to get the and they had to do that because the number of incidents was so low that they needed all 6 of those endpoints as a combined endpoint. The other thing about the Callisto trial is if you look at the data table as to the actual number of pulmonary emboli and the actual number of DVTs, there was less than 1% of those patients had a pulmonary embolus and less than 3% of those patients had a DVT. So that's in stark contrast to the earlier trials that you showed. And I think one of the reasons in my mind why there was such a difference is that the trials that were done in 1996 and maybe the early 2000s, the anticoagulant that was used was Coumadin. So most of those patients had to be admitted to a hospital, placed on IV heparin, then converted over to Coumadin. And we really don't know whether or not they were therapeutic. So how many of those thrombus extensions or contralateral DVTs was actually related to subtherapeutic levels of their Coumadin, whereas with the new factor 10 inhibitors, you know, the likelihood of having subtherapeutic levels is lower. And I think that what I got out of the Callisto trial is that if you get good levels that are maintained, your likelihood of getting a DVT or a pulmonary embolus is very, very low. The other thing that's not really reported in a lot of these trials is pain. If it wasn't for the fact that these SVTs were so tender, most patients wouldn't even know they have them. But that's never really an endpoint. And what I've noticed personally in my own experience is that apixaban and Xarelto or rivaroxaban, they have an anti-inflammatory effect as well as an anticoagulant effect. And I've always been amazed at within a day or two, most of the patients say that their pain is significantly improved with, the new factor 10 oral inhibitors. And finally, we still don't know whether or not there's any value to compression in an SVT. I mean, I personally think there is, not because it helps with thrombus resolution, but again, because it helps with pain moderation. So, what are your thoughts on those things?
So I actually, the more or less taking a reverse, just because you just mentioned the compression, and we're going to have a article on Journal Club about compression stockings and the need after treatment. But I agree with you. I think it's more of a pain issue. I think it's sort of that ACE bandage support effect. And it's not for any resolution. Just like you alluded to, I have noticed the exact same thing with regards to the DOACs and even the low molecular weight heparin. I knew that, and I'd seen it from before when we used to use low molecular weight heparin a lot more frequently, that it does seem to have an anti-inflammatory effect. Also, with the luxury that we have of serial ultrasounds, I noticed that these DOACs, when we do these serial ultrasounds, I see resolution a lot quicker of this thrombus versus what we used to see with the warfarin and Coumadin. To the point that sometimes now I wonder, obviously we don't have any new studies, but everything is said that we should treat these patients for 3 months, 6 months. And back then, those set points had been created, but I'm wondering if we need to keep patients in anticoagulation as long as we do anymore, especially if we have an ultrasound that's demonstrating total resolution of the thrombus, right? What are you treating at that point? There are no studies, but I think these are all things that will probably be hopefully coming down the line, though probably not by pharmaceuticals, as it will cut the length of treatment and saving to the patient. So
yeah, and also for the fellows, don't forget there is a surgical option as well. I mean, as Dr. Fernandez pointed out, 70 to 80% of these SVTs are in patients that have varicosities. So when you get a thrombosed varicosity that's extraordinarily painful, even the DOACs take some time to kind of resolve some of the pain and discomfort. Sometimes it's easiest just to give them a little local anesthesia and do a thrombus removal for those patients, and then anticoagulate them afterwards, just for pain resolution purposes as well. So don't forget that as a treatment option in your hip pockets. And then finally, there's always this big concern about, oh, it's close to the saphenofemoral junction, it's close to, back in my day when I was a fellow and a resident, we would ligate those patients if it was close to the saphenofemoral junction. But I think now with the new oral anticoagulants, I think that's just not necessary. They work really, really well. And I think the need for surgical intervention in those patients is unnecessary. And then I've even had some patients back when I was younger, we had to put, filters in those patients because they had contraindications to anticoagulation. So that still pops up every now and then in patients who you can't anticoagulate. So just keep all of those treatment options in mind. And then now we even have endovascular options now where you can put a catheter in there if it's, say, like a mobile thrombus and you're really concerned, and you can actually evacuate those thrombi. We've done that in a couple of patients who had glue-induced thrombi, for example, as well. So there's multiple options in the toolkit if you have thrombi at the saphenofemoral junction and you've got relative or absolute contraindications to anticoagulation as well.
Peter.
Peter, may I just say a word?
Sure.
I really echo the point you made about the pain in superficial venous thrombosis. It is really the thing that really brings the patient. It is the thing that is also very meaningful to the patient. And as you said, compression, there is not much data on this really at all. Yet compression does actually improve the pain. And as Eddie mentioned, the paper that he will be discussing in our next journal club, it's a review article, and although it shows that compression improves only the pain problem after ablation, it is a similar situation. Compression does help, and I think we need some data more. Don't you think?
Yeah, no, I agree completely.
Also want to add, I had a case recently that I discussed with one of our former fellows. a patient that we were following up, and this is to what you were talking about, Peter, who had a initial documentation of chronic venous insufficiency, then presents scheduled for conservative stocking trial for 3 months. During that period of time, presents with an SVT of the GSV. Followed, there is some extension from below the knee to just above the knee. So one of the conversations was at that point, what do you do? Obviously, anticoagulate is very much on the line. But one of the other things that I decided to do, we know that they needed treatment. We knew where they had the thrombus. And what we did is we accessed above that and we ablate it just above. So that prevents progression immediately of that thrombus, right? So don't forget that if you ever have a thrombus in which you are concerned for extension, you have documentation that the patient has venous insufficiency, you can always close above that thrombus and prevent the progression. You can still anticoagulate them for the for resolution of the thrombus, the pain that we discussed. So,
yeah, I think another point that Dr. Fernandez mentioned in his talk is the association of an SVT and say an axial vein that does not have a varicosity with cancer. So I think that was a one slide point, but it's a very important point because as vein specialists, we're not immune from the risk of missing the diagnosis. So if you have a patient who has, say, an unprovoked SVT in an axial vein, who's at the appropriate age and has risk factors, you need to think that there may be an underlying malignancy in those patients and make sure that they get a workup, especially if they have risk factors associated with it. The other category of patients that should raise your concern is if you get recurrent SVTs. There is some data to suggest that those patients may or may not have an underlying hypercoagulable disorder. I know the data is weak on it, but again, in the back of your mind, someone who has unexplained recurrent SVTs, you should maybe consider that patient to get a hypercoagulable evaluation as well.
And I'll add to that, Peter, if you have a DVT out of proportion, okay, of what you should see, and I'll bring you just a brief case study. I had an RF with a patient who had a normal 3-day follow-up, and then 5 days later, she presents with this thrombus throughout her entire common femoral vein, a very extensive center-ended. They actually, in the hospital, they decided just to put her on Eliquis and do no thrombolysis or anything further. They actually did not study the abdominal cavity. It was when I follow up with them the following day, they're like, "Oh, this is just from your procedure." Well, I'll tell you, and we all know that that kind of thrombus is not normal. I've never had somebody with that extensive thrombus post-procedure. So I got her to a different facility. They did do a CT of the abdomen. She had a metastatic disease from a GI sarcoma. Okay, again, to just follow your instincts. We do this every day. We do RFs. We see small DVTs all the time. But if it's out of proportion to what you normally see, follow your instincts. Think that person might have some kind of hypercoagulable disorder.
Yeah, I think that's a really good case example there. Because again, it doesn't obviate your responsibility to the patient in making the appropriate diagnosis. And I would also add to that, you know, I think one of the strengths of CVR is that we're very good about calling the referring physicians and the primary care doctors and sharing our concerns with that. And, you know, you don't have to do the workup yourself as long as the primary care doctor does it, but you do have to make sure that you follow up with the doctor and the patient and make sure that they got the workup done, especially if you've documented in your notes that this may be a concern. You're on the hook for the care of that patient.
Interestingly, Peter, we have a paper that we have chosen for next journal club that discusses presence of deep venous thrombosis within how many of those people do develop malignancy, and within 6 months, not people who are known to have malignancy, but then have DVT, but the other way, DVT as being an indicator and alerting us to be careful, just like Eddie, you said. And everybody, please keep a look at that paper, and because it also gives you the type of malignancies related to what is happening. Just mentioned to give a point for everybody.
Yeah, and not to beat this dead horse, but I recently also had a patient who came in with a extensive iliofemoral DVT, and when I examined her, she had a very rigid thigh mass, and then ended up being a sarcoma of the hip. And it was we was all diagnosed with her being sent originally for the DVT and then physical exam, and she I sent her to Dr. Smith, who did the iliofemoral thrombectomy. And while she was admitted to the hospital, she had the biopsy of the mass, and it turned out to be a sarcoma. And she's right now getting radiation and chemotherapy, and we caught it early before it spread to her lungs and her bones. So I mean, it does happen. So, and I really want to emphasize that for the fellows, that you can't stop being a doctor once you see these patients, and you have to keep in mind these relationships, because you will see them in your practice if you do this long enough. Anybody else have any questions for Dr. Fernandez? All right, thank you very much, Eddie. As usual, high quality, very good. Thank you so much.
Appreciate the opportunity. Thank you, everybody. Have a great day.
Have a great weekend.
Thank you, Eddie.